Okay, so first of all, if men live together peacefully, we never have expanding valves. And the reason is that every self-expanding medical device that I know of is made of a material called nitinol, which was developed in 1959 specifically to make missiles. So something good has come out of that. And what you need to know is that nitinol has a shape memory effect. So you deform it at one temperature, and it retains that shape. And then when you heat the metal above its so-called transformation temperature, it changes its crystalline structure and its shape. And that's very convenient because you can adapt that transformation temperature based on the alloy that you choose, based on the proportions of nickel and titanium. So what we do is we crimp this material at low temperature, and then at body temperature, it expands very rapidly. So what does that mean? Well, that means that it's a more forgiving valve, less radial force exerted on a calcified and fragile annulus, slower deployment of the valve, and what I'll show you is that we deploy these valves very slowly, and in fact, you almost can't be slow enough. It's more forgiving. It's easier to adjust the position. It means that you can implant the valve so that you seal at the annulus, but the valve itself, so the thickened material is above the annulus, so you don't have to layer things together. And then the other advantage, the other implication is the so-called while we sleep phenomenon that we joke about. The valve continues to expand after implantation. So in fact, when you look at the rate of paravalvular leaks, as you follow patients, the valve continues to expand and continues to seal at the annulus. The rate of PVL decreases as you follow patients along, for mild to moderate leaks, at least that is. And that's perhaps why we don't see that same mortality risk with PVL that we detect acutely. Okay, so these are the core valve designs. This is the first self-expanding valve on the market. I show you a slightly older design. So again, it's available in a variety of sizes. The lower three sizes are available in a newer design known as the Evolute, which is designed so that the valve itself is shorter. The radial force is distributed a little more uniformly along the length of the valve, makes it a little easier to control. Evolute is shown in the corner. You can see it looks a little bit different than the classic core valve shown in 31 millimeters. It's not quite as conical. The inner lining, the skirt, comes down a little bit lower. So you get a little bit better seal. Again, 4 sizes available. Access, as you probably know by now, transfemoral, subclavian, or direct aortic. One of the disadvantages of that sort of design is that this valve expands against the left ventricular outflow tract, and if you recall, that's the area where the bundle of His is located. So there is, at least has been initially, a higher pacemaker placement requirement with this valve. Shown here, though, there's a tremendous amount of variability. Remember, half of these AV blocks resolve over 6 months, so there's a lot of physician judgment involved in who does and doesn't require a permanent pacemaker. This is the current delivery handle. You can see one outside. You probably saw one during the live case yesterday. This is the official advertising picture of the delivery system, but it really has become very easy for us to use. You can grasp it easily. It's currently a very forgiving valve. If you don't like where it's starting to locate, you can recapture it inside the sheath. Generally, it's become easier to use as it's evolved. So here's how we do it. We start with a balloon valvuloplasty. Unlike the balloon expandable valves, we're more aggressive about this. We started being very shy, very timid about balloon valvuloplasties. But the one thing we've learned is you've got to crack some of the calcium nodules on the valve, soften them up, so to speak, so that the valve can expand. And then here's a deployment. I'm sure you saw this yesterday. What we do is we start a little bit distal to the valve, and then as you uncoil the handle, you actually pull the sheath back so that the valve expands, as shown in this video and in the still shot below it. And we check that with serial contrast injections, although with transesophageal echo, we have done an implant with no contrast whatsoever, and really with a very acceptable result. And then finally, this is just my backup video. Well, finally, what you're meant to see is that as we pull the sheath further back, the valve itself springs open. It's fully released from the sheath. There are two paddles at the upper end that fit on prongs on the delivery system. So you're meant to see it springing free here, but the video unfortunately won't play. Now, there's another self-expanding valve being developed. This is the St. Jude Portico valve. If you look at this, this looks very much like a core valve. It's got some differences. It's a much more flexible system, a little bit smaller in delivery size in its current iteration. And the other thing you may notice is that the cells are much larger. The idea being that they fit in the calcified annulus more freely. So you, at least in theory, get a better seal with this valve. Now that trial's ongoing, we don't know that yet, but that's the reason for this particular design. Now this valve, rather than being supra-annular like the core valve, is annular in design. So the valve itself, instead of being several millimeters up from the base of the valve, is located at the base. And what does that mean? That means if you do CT scans and you find the virtual annulus of the aortic valve, that's where this valve sits. And is that good or bad? We don't know. Potentially, that makes it very easy to place the valve. On the other hand, it may be subject to deformation by the narrowest and most calcified portion of the valve. We'll learn that as the trial progresses. This is the core valve, just meant to show you a little differently what we mean when we say it's supra-annular. And what you can see is that if you look carefully, the valve annulus, the native annulus, is right down here. The valve itself is way up here, so you can see the prosthetic leaflets opening very nicely in this picture. So native valve plane, prosthetic valve plane, very different. So this is what a supra-annular valve looks like. And again, the theory being that the bulkiest portion of the valve is not down in the portion where it may be constrained by the native annulus. And in fact, this is a cone beam CT that we've done on a patient with a valve implant. And what I've done is I've shown you 3 serial cuts at different levels of the valve. And you can see that the valve profile becomes more circular as you advance upward from the annulus. So it's deformed at the bottom. It's not meant to be circular in the annulus. This is meant so that you don't have to dilate it aggressively with a balloon. Very hard lesson for coronary interventionalists to learn. But as you move upward toward where the prosthetic valve sits, then the valve is in fact circular, allowing the prosthetic valve to function. So what do we know about the valve? What have we learned? Well, this is the design of the US pivotal trial. Patients were originally stratified into two different studies, extreme risk or high risk, which were originally both designed to be randomized. However, as things progressed, Partner B became available at the time we were doing the extreme risk study, and it became clear that ethically, based on Partner B findings showing a markedly improved survival with TAVR compared with medical therapy, we couldn't ethically perform randomization. So extreme risk was then studied against a performance standard that I'll show you in a minute, based on a meta-analysis of balloon valvuloplasty studies, while high risk consisted of patients who were operable but considered by the team to be at high risk for surgery. Randomization was performed between surgical valve replacement and transcatheter valve replacement. Inclusion criteria are very standard for most clinical TAVR trials: severe aortic stenosis, symptomatic, New York Heart Association Class 2 or greater. For the high risk, 30-day mortality, 15% or greater, and combined morbidity mortality within 50%. Patient eligibility, as in all these trials, was reviewed and verified by a national screening committee. And these are the data from the core valve pivotal trial. So again, we had a performance standard of 43% based on a meta-analysis of balloon valvuloplasty studies. In fact, this is what the control, almost exactly what the control group study in Partner B looked like. And in fact, at 1 year, we very clearly beat that performance standard. This graph shows you 2-year data. And at 2 years, we were still better than the performance standard, but also better than the Partner B medical treated group by a considerable amount, nearly 20 absolute percentage points. What about high risk compared with surgery? Well, the primary endpoint was at 1 year. This was death, or rather all-cause mortality or stroke, superior to surgery. That was the primary endpoint, but followed out. Dr. Reardon presented the 2-year data at the ACC, and we've this year seen the 3-year data. So at 3 years, there's clear superiority for TAVR compared with surgery. This is not an identical group to the group studied in Partner. The risk is somewhat lower, but the difference is still really clear, and the absolute difference in death or stroke, nearly 10%. So it's serious business, and it appears that as you get into lower risk patients, you may actually end up doing better than with surgery. We don't know that, but when these patients were stratified at the mean STS score of 7, the differences for patients in the 7 and higher group between the two treatments was identical to the difference observed among those who were 7 and lower. So granted, they had to be judged to be high risk, but regardless of where the STS score fell, the differences were nearly identical. And this just shows you a variety of breakdowns, all-cause mortality or major stroke, all of these favoring TAVR over SAVR. No subgroups stood out, so uniform findings among the subgroups within the randomized trial. So where are we? 2016. So for core valve, I've color-coded this for my benefit. Extreme risk and high surgical risk are FDA-approved indications for valve implantation. Intermediate risk, the trial CERTAVI is ongoing. We don't know. So if someone's intermediate risk, often they prefer a less invasive procedure. We don't know which is better. We sort of have our suspicions, but we try to keep equipoise on this issue, and we are not currently FDA approved to enroll intermediate risk patients on a clinical rather than a research basis. Low risk, an all-comers trial as it were, this trial is beginning. So we don't know that. For the Portico valve, this valve is in its clinical trial, which has started recently. These are extreme and high-risk surgical patients. So I'll leave it there. Thank you.